So, welcome to Shoulder Anatomy from First Principles. This is a little YouTube series that I'm starting, and this video is specifically going to focus on how the shoulder maintains its stability. So, the shoulder joint is kind of like a Formula One car, in that it's very mobile, very agile, it can move very quickly, but that comes at the cost of stability. Compare that to something like the hip joint, and here we see the human pelvis and the femur and the hip joint, and it's a very sturdy, stable joint, but it's not as mobile. So whereas the shoulder is like a Formula One car, the hip joint is more like a tank. It's built for durability, and the reason for that is because the upper limb and lower limb have two fundamentally different purposes. The upper limb is the limb of manipulation, whereas the lower limb is the limb of ambulation. Okay, so the lower limbs get you where you need to go, and the upper limbs allow you to interact with the world. And that's that. So there's a paradigm in biomechanics called the mobility-stability trade-off, where if you increase mobility, you usually have to decrease stability, and vice versa. And the shoulder and hip joints are the polar opposites in this respect, so they have tilted the scales in opposite directions. This then raises the question of, since the shoulder is the most mobile joint in the body, how can it still remain stable? Because it needs to remain stable, because otherwise people's shoulders would just pop off left, right, and center, and we can't have that. So this video explains how the shoulder maintains its stability. Here's our table of contents. We'll look at the bones and joints that form the shoulder. We'll look at connective tissues that help with stability. We'll look at the rotator cuff muscles, and we'll finish with a recap and closure. So let's start with the bones and joints, and we'll end up with a bit of a definition of what the shoulder actually means, because we need to actually be able to define that. So the bones that we actually need to know in order to understand the shoulder are the sternum here with its three parts, the manubrium, the body, and the xiphoid, but we'll focus mostly on the manubrium. The clavicle here, the S-shaped bone. The scapula, this irregularly shaped bone, also known as the wing bone. The humerus, so the lung bone of the arm, where arm is this bit and forearm is this bit. And the first rib, and we'll come on to why. So here are some pictures of bones for your education. So we'll figure out why all of this is important. So the shoulder is not sort of straightforward to define, because we need to talk about the shoulder girdle and the glenohumeral joint separately. So if we go back to this picture and we look at the clavicle and the clavicle and the scapula, together they form something called the shoulder girdle, which is the mobile base of the shoulder. So what happens is you've got the clavicle here with a sternal end and an acromial end. I believe it's that way around. And the sternal end attaches here to the manubrium of the sternum and lies flat along here. And then the acromial end connects to the acromion of the scapula. So this is the scapula, this is the acromion of the scapula, so the lateral most protrusion of the scapula. Okay, so you'll have the clavicle inserting here, and then the clavicle inserting onto the manubrium, and that's the shoulder girdle. And the point of that is basically that this allows the scapula to move about with the help of the clavicle, so that the shoulder joint, or the glenohumeral joint here, can change positions, and it increases the mobility. The final thing that the shoulder girdle does is it actually helps connect the upper limb to the axial skeleton, and the axial skeleton is the skull and the spine and the pelvis, okay? And the way it does that is you've got the humerus, which connects to the glenoid fossa of the scapula, and then the scapula has an acromion, and that connects to the clavicle, and the clavicle connects to the sternum connects to the rib cage, and the rib cage connects to the thoracic vertebrae, and thus the upper limb is connected to the vertebrae. Ain't that beautiful? So there's a few bony landmarks that we should probably talk about, and we should perhaps start. We've talked about the scapula, the clavicle. I always mix up scapula and clavicle, which is really bad for a video about shoulders, but bear with me. So we've talked about the clavicle, the collarbone, and now we'll talk about the scapula or the wing bone, okay, or what's it called, the shoulder blade, yeah? So this is an anterior view of the right scapula. Here we have something called the infraspinous fossa on the lower surface, and here this bit, and this bit is what's called the glenoid fossa. Okay, so that's the articular surface for the glenohumeral joint. And when people talk about the shoulder joint, that's what they usually mean. They don't mean the whole shoulder girdle thing. They're talking about how the head of humerus plugs into the glenoid fossa, okay, and forms a ball and socket joint. Okay, we've talked about the acromion. This bit is called the coracoid process. And then you've got, on the posterior side, you've got a spine of scapula, supraspinous fossa, and infraspinous fossa. Let's talk about the humerus. We're going to focus only on the proximal humerus and ignore the distal humerus altogether. So this is the head, which has the articular surface, and there's a surgical neck. No, I'm wrong. This is the anatomical neck. Okay, so there's two necks. There's the surgical neck here and the anatomical neck here. The surgical neck has a bunch of neurovascular structures around it, hence its importance to surgeons. The anatomical neck is, well, actually attaches to the head, which makes sense. Then you've got something called the greater tubercle, the lesser tubercle, and an intertubercular sulcus. And I should point out that this is the anterior surface of the right humerus. Okay, that's enough about bones. Let's actually talk about the stuff that connects the bones together, which is connective tissue. So ligaments and labra. Okay, so let's define the term. So a ligament is a piece of connective tissue that connects two bones, and a labrum is, I don't know how you would define it. It's like a piece of connective tissue inside a joint that helps improve the joint, increase the joint surface area. So these are a bunch of pictures of sterna, okay, or, you know, I think that's the plural of sternum. Anyway, so we've got the sternum here with the xiphoid process, body, and manubrium around there, and you can see that it's covered in a bunch of connective tissue. Okay, this is the anterior surface, this is the posterior surface, and this is again the posterior surface, but just the top bit. And the clavicles are here, and here, and here, and here, and here, just above the first ribs. Okay, these are the first ribs. And there is a sternoclavicular joint, which is a genuine synovial joint, which contains an articular disc inside to help increase the surface area. And there's a joint capsule, and around the joint capsule there's a couple of ligaments. So there is the anterior sternoclavicular ligament, the posterior sternoclavicular ligament, and the interclavicular ligament. And the point of this is to help prevent dislocation, and I'll say that the posterior sternoclavicular ligament is particularly important because behind this, so posterior to this, are structures like the trachea and the carotid arteries, and a posterior dislocation is therefore a bit of a disaster. Here we also have something called the costoclavicular ligament, which attaches the first rib to the clavicle. And we can also see it here and here, and you can see it there. And this structure helps prevent distraction of the clavicle, so prevent upward distraction. And we can always look at the direction of the fibers to kind of infer what they do. So the posterior sternoclavicular ligaments, interclavicular ligaments, and anterior sternoclavicular ligaments, they're all kind of aligned this way, so obliquely and laterally. And what that tells us is it prevents the ends of the clavicle, it prevents these clavicles from being pulled apart from the sternum. Because if they were pulled apart from the sternum, the whole force transmission from the axial skeleton wouldn't really work. Okay. I think that's probably enough about this. Now let's talk about the connective tissues around the glenohumeral joint. So here we have the clavicle, the scapula, and the humerus in various different projections. Okay, clavicle, scapula, humerus, clavicle, scapula, humerus, clavicle, scapula, humerus, and these are all the right side shoulder girdle and shoulder. Okay. There are some. So here we have a sort of cutout diagram where the joint capsule has been opened, and we can see the articular surface of the head of humerus and the glenoid fossa. And you may be able to appreciate that around here is a little rim of connective tissue called the glenoid labrum, and that extends the surface area of the glenoid fossa, and by extending the surface area it reduces wear and tear and provides stability. It's probably more important in the extremes of range of motion. Okay, if we then sew this capsule back together and look at, for example, this picture, you can see, okay, ignore this. This is probably, that's probably subscapularis tendon, but we can ignore that for now. Let's just look at the joint capsule. So the joint capsule is made of these fibrous ligaments called the glenohumeral ligaments. And there's a superior, inferior, and middle glenohumeral ligament. And the fibers again run this way, so they prevent the humerus from being pulled apart from the scapula, which is really useful. Okay, and it helps prevent dislocation. And inside the joint capsule, there's a constant slight negative pressure. So if you think about it, the humerus is often pulled downwards if your arm is dangling. It's pulled down, and it's a sealed chamber, and that creates a negative pressure. And even in neutral position, it's got a negative pressure compared to the atmosphere, and that sucks the head of humerus into the glenoid fossa, creating a suction cup effect, which also adds to the stability. Then we can talk about the acromioclavicular joint here, so the joint between the acromion and the clavicle. There's an acromioclavicular ligament which prevents the ligament from being pulled apart. The fibers run in this direction. But then there's also a couple of very important ligaments called the coracoclavicular ligaments. Okay, so the coracoclavicular ligaments run between the coracoid process and the clavicle, and there's basically two of them. There's the trapezoid ligament here and the conoid ligament here. I think that's the way around they go, but you can double check that if you're studying for an exam. And what these do is the fibers run this way, so they prevent superior distraction of the clavicle. So they prevent the distal end of the clavicle from being pulled upwards, which helps take some of the shear force that would imply away from the acromioclavicular ligament, okay, or the acromioclavicular joint, which also protects that joint. And these are actually important structures that if they get damaged might need to be repaired, but that depends on what your shoulder surgeon happens to think of the situation. I think that just about covers the connective tissues at this point that I wanted to cover in this video. So next we'll talk about the rotator cuff. The rotator cuff is a very unique structure for the shoulder because it's a bunch of muscles that pull the humerus towards the glenoid fossa, making it stable in various different positions. So this is a very, very intelligent structure that provides dynamic stability for the glenohumeral joint in various different positions. And here we again have the right shoulder from various positions. Okay, so posterior view, lateral view, anterior view, anterior view, anterior view, and lateral view. Okay, and we'll look at a few muscles here. So first of all, here you can see the deltoid muscle. Here you can see, I think that's probably a bit of, there's probably a bit of trapezius, sorry, not triceps there. And the rotator cuff muscles can be seen here, 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 and here. Okay, so there's 4 of them. There's 4 of them and only 4. And this is actually possibly the best diagram. So this is the right shoulder, anterior surface, posterior surface, superior, inferior. Okay, this muscle is the subscapularis muscle. We can also see that muscle here. So it originates from the subscapular fossa and inserts into the lesser tubercle of humerus. And what it does is it performs internal rotation of the shoulder and pulls the glenoid, so pulls the humerus into the glenoid fossa. Then we've got supraspinatus here and here, and we can see a little bit here, here, and here, which is the muscle that originates from the supraspinous fossa, so the fossa above the spine of scapula, and it goes through and goes that way, and it dives below the acromion, and going below the acromion, it inserts into the superior aspect of the greater tubercle. And what it does is a little bit of glenohumeral joint abduction, and it again pulls the humerus into the glenoid. Then we have infraspinatus here, and here, and here, and oh, can't see it there, can't see it there. Oh, there we can see infraspinatus. This diagram you can't see infraspinatus, which is the muscle that originates from below the spinous scapula on the posterior surface. This muscle originates from the infraspinous fossa on the posterior surface, and it inserts into the greater tubercle again. And that performs external rotation of the shoulder, and again, pulls the humerus into the glenoid. Finally, we've got teres minor, which is here, which is the 4th of the rotator cuff muscles, originating from the lateral border of the scapula. The lateral border being here, this bit, and by originating from the lateral border of the originates from the lateral border of the scapula, and it inserts into the sort of lower posterior aspect of the greater tubercle of humerus, and it does external rotation, and again pulls the humerus into the glenoid. And that's the big thing about the rotator cuff muscles, is when there's all kinds of forces being applied on the upper limb, the rotator cuff muscles help pull the humerus into the glenoid fossa and therefore stabilize it, allowing it to be very mobile. And they can do these in various different positions because they are muscles. Okay, so your shoulder can be in external rotation, internal rotation, abduction, whatever flexion, whatever position, the muscles can still pull it inwards. It's worth mentioning at this point that teres major, which is seen here and here and here and here, might be this one. This might also be either pec major or lat dorsi, but the teres major muscle is not a rotator cuff muscle. It is not a rotator cuff muscle. Okay, only the teres minor is. Okay, and the reason for that is its insertion point is further away from the glenohumeral joint, so it doesn't contribute nearly as much to the effect of pulling the humerus into the scapula. How many times can you say that in one video? Anyway, let's recap. So the shoulder is the most mobile joint of the body, but it comes at the cost of stability. I think it's the most commonly dislocated joint of the body as well. I might be wrong, but that would make a lot of sense. The ligaments around the glenohumeral joint and around the other joints of the shoulder girdle, the negative joint pressure in the glenohumeral joint, and the glenoid labrum help provide some ligamentous and passive stability. The rotator cuff muscles provide dynamic or active stability by allowing the humerus to be pulled into the glenoid fossa in various shoulder positions. And thus, the most mobile joint of the body can remain attached to the body by the miracle of biomechanics. And that's basically that. So thank you for watching. I'm going to make a couple more shoulder videos soon. I'm going to make one about force production, so the big muscles that you like to train at the gym, like the delts and pecs and lats and whatever. I'll make a video about vascular anatomy, because that's particularly relevant for me, studying for the MRCS. And I'm going to make a video about neurological anatomy as well, so, you know, brachial plexus and that sort of stuff. I probably forgot to mention who I am. So I'm Arrow. I am a doctor working in the UK, and I am planning to do surgery as a career, and therefore I have a very, very great interest in anatomy. And I am going to bring you more anatomy videos in the future. And I try to make these videos such that you understand the underlying principles, the first principles, okay? So this video was entirely about the mobility-stability trade-off, and therefore explaining the ligamentous anatomy and rotator cuff anatomy of the shoulder. So that's the sort of video that you can look forward to in the future. So please subscribe to the channel if you want more videos like that, and please share this video if you thought it was useful. Thank you for watching. Bye bye.